The information in this podcast is provided for education and research information only. It is not a substitute for professional health advice.
Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And thank you for joining us on what we're going to do today, which is another SpeakPipe Q&A.
Good.
We've got so many great questions. I want to begin by thanking everyone that joins us every week. Like, your dedication is amazing. And welcome to all our new listeners. Welcome aboard. We are an expert-led podcast and we hope that we can help you feel a bit more calm and confident during your pregnancy, birth and beyond. People come onto our website, growmybaby.com.au, and they leave a question for us on the SpeakPipe link. It's great to hear people's voices, isn't it, Pat?
It's fantastic because that's, I don't know, it just adds a certain something to hear your actual voice. So if you've got a question and you want it discussed or an idea for a whole episode, get on the SpeakPipe and let's hear from you in person. This
person has rung back, Pat, put another SpeakPipe in to tell us what happened after the last time. So she was a few months ago and she'd had a miscarriage and the sonographer had sort of in the process of doing the appointment said, look, it looks like you've got a septate uterus. And we gave her some information around that. So she's come back to us and this is what she's done.
We've got it now.
Yeah,
okay,
we've got a follow-up.
Exciting.
Hey, Brigid and Dr. Pat, Michelle here. I reached out recently because I'd just been diagnosed with a uterine septum and I thought I'd give you an update. So I went to get a specialist ultrasound and they confirmed that it was certainly there. I also went to see a specialist gynecologist who gave me the option of either leaving it and trying again to have another baby or resecting it because the data is mixed. He said it was totally my decision and gave me the pros and cons of everything. We decided to go ahead with the resection and I went in just last week. So they went in laparoscopically and did a hysteroscopy as well. So laparoscopically to kind of see everything. While they were there, they also found some endometriosis, which was interesting as well. But they were able to resect 80% of the uterine septum. They said it was 3 centimetres wide and ran the entire length of my uterus. So I'm really relieved that we decided to go ahead with a resection because it sounds like it was quite big. So now I am taking estrogen to build back the lining of my uterus, and then I'll take 10 days of progesterone after that to get my cycle back, and then we'll be able to start trying again for a baby. So yeah, it's been a pretty wild last couple of months, but I'm really stoked that now I'm just in this recovery phase and, really thankful for all of your insights and knowledge on this topic as well. It's really helpful.
Fantastic.
There we go.
Yeah, great. So awesome feedback. So just in case people didn't hear the other bit, a septum is a sort of an abnormal wall that can form in the middle of the uterus, typically a congenital thing, something that would have been there all along. And there's a probable correlation between that and early pregnancy loss. It may be that the pregnancy finds it difficult to implant successfully in the presence of the wall. And what the gynecologist was saying about the data being mixed is very true. We're not entirely sure. Certainly tons of people in the history of the world have had a septum and have had babies, no dramas. But some people, we think, have experienced recurrent pregnancy loss because of the septum. This is a terrific example of a surgical problem where it's not like appendicitis. You come in, have your appendix out, and you're fine. And we clearly know that if you've got appendicitis, that there's an overwhelming case for surgery. This is one of those situations where there are pros and cons, and there's even a small possibility that if you did nothing, you would still get pregnant and still have the family size that you wanted. But there's a possibility that you would continue to experience first trimester loss because of the problem. So we sit down, we discuss the pros and cons, and she's elected for surgery. It sounds like it's gone very well. The laparoscopic approach, just with the telescope from above, presumably was just so they could watch what they were doing. The septum itself is removed with a hysteroscopic approach, so going in through the vagina and through the hole in the cervix and operating inside the uterus to cut the wall away. But for safety reasons, if you watch through a laparoscope from above, have your assistant looking back the other way, you could make sure that you didn't cause any damage to the uterine wall by watching that way.
And in this caller's case, probably luckily she also had a laparoscopic approach if they found some additional endo.
Yeah, isn't that interesting?
Yeah.
So that happens all the time as well. We operate for some reason and we find endometriosis. So just recently I was operating on a young woman with a ruptured ectopic, and at the same time as taking out the tube, we found endometriosis. Often if we're doing a hysterectomy on a woman in her 40s for heavy menstrual bleeding, we'll find endometriosis that's been there all along, and that's just a lot to do with the nature of endometriosis. It's not always obvious. It doesn't always get diagnosed. It doesn't always get treated. And sometimes we'll just find it there as a bit of a surprise when we're operating on something entirely different.
And also, the caller didn't say whether she had painful periods or not, or any issues because of the endo, but sometimes endo isn't painful.
Yeah, that's right. So sometimes we'll find endo when we're investigating infertility, for example, where there's no great symptoms of endo. Pain with intercourse, pain with the period, nothing. It's not that strange to find it. It's a common problem. And it's not that strange to find it in someone who didn't have an overwhelming symptoms of it either.
Mm.
The good news is that treating endo helps with fertility as well.
Yeah.
So taking out the septum and fixing up the endo, we've got great optimism for this patient. I hope she keeps in touch. I'd love to hear how it ends up.
Yeah, did you hear that? You have to call again.
Yeah, call again.
Thank you so much for updating us. That's really great. All right, we're going to go on to this caller, Patty.
Hi guys, my name's Nicole and I love your podcast. Thank you so much for everything you do. I'm currently 32 weeks pregnant, and when I was about 25 weeks, I ended up in hospital with a DVT. Unfortunately, it's quite extensive and I can't see how high up it goes due to my uterus, but somewhere up in my groin, in my hip to down sort of almost to my ankle. Unfortunately, this has left me with quite a bit of lack of mobility and pain in my left leg. I've been told that I'll need to be induced at around 37 weeks or a planned C-section at that time, so they can stop the blood thinners. But my question is, if the clot is below my knee, my specialist has recommended, she's more comfortable with me attempting a natural birth, a vaginal birth, but if the clot is above the knee due to risk of a PE, they are advising a C-section. Due to the unknown nature of birth, I'm a bit hesitant about going for a natural birth with potentially a clot that could dislodge and cause a PE. Just wondering, have you experienced anything like this, and do you have any recommendations? Thank you.
Yeah, wow.
Bit complex.
Yeah, that is a complex situation and a really interesting clinical dilemma, isn't it? Just to break it down a little bit, when someone's diagnosed with a deep venous thrombosis, typically in the leg during pregnancy, we go on these blood thinners. It's usually something called Clexane, an injectable daily dose blood thinner, and it just helps stabilise the clot and reduce the chances that that person's going to go on and get a pulmonary embolus, which is where the clot from the leg breaks apart and bits of it wind up in the lungs. The problem is that you don't really want to be anticoagulated in labour. Labour's bleedy enough as it is, and even if you're not going to labour and have a caesarean section, that's bleedy enough as it is without being anticoagulated at the time. So what we really want to do is stop the Clexane a day before the baby comes, however that baby comes. And the only way we can really know when a day before is going to be is by intervening with an induction or a planned section, so that we've got a day to stop the Clexane, wait 24 hours for the anticoagulation to reverse, and then either induce a labour or do the section. So that's pretty much standard advice. It does involve interfering, but if we don't interfere, we might wind up in the situation where you've just given the Clexane, half an hour later you're in strong labour and you have the baby or a Caesar anticoagulated, which is potentially dangerous. As to the mode of delivery, that's a really complex question. I don't know that we've got enough information here about the technical details of what's going on to comment in particular. But what I can say is that there are frequently therapeutic dilemmas that come up in obstetrics. We say, on the one hand, we could do this, and on the one hand, we could do that. And there are real pros and cons to each approach. And it just shows the importance of being part of a therapeutic team that you really trust. So typically in this situation, we'd involve some senior obstetricians who'd seen this stuff before, who had some strong feelings about perhaps which is the best way to go. We might involve haematology when we're talking about the anticoagulation. Sometimes yes, sometimes no. In the setting of a DVT, we probably would. And then ultimately, the decision rests with the patient, but it's really our advice to counsel that person as to the wisest way forward. I'm guessing that some of the reticence of the treatment team to do a vaginal birth in the setting of a big DVT might be just due to that woman's immobilization in labour. And then, if we are in labour and we have to get into certain positions, push the baby out, move around to keep the labour on the ball, those sort of things, could that disrupt the clot? And, there's some ifs and buts there.
Because she did say she has quite a lot of pain in her leg.
She's immobile now.
Immobile, yeah.
Yeah. What about at the time of the delivery? So there's some ifs and buts there. We don't exactly know the situation. It's one of those therapeutic dilemmas. And sometimes in obstetrics and in all branches of medicine, there's a 100%. This is the smartest decision. This is what you should do. And then sometimes there's real grey areas. I think as the longer I've been a doctor, the more comfortable I am engaging in those grey areas. And it's also good to have a patient who is engaged in the therapeutic dilemma, understands the problem, and is also capable of engaging in the complexity as well.
Because isn't one of the complexities of a caesarean section a DVT or a pulmonary embolism?
Yes, it sees as an operation. So pregnant woman's clotting to start with, and then you're throwing in an operation. So it's got its own risks. Yeah, and they'll be weighing up all of those. Yeah,
and we don't know whether this is this patient's first or second or third baby. So if we knew her birth history and you knew that she had reasonably uncomplicated vaginal births, then you'd probably be erring on the vaginal birth.
Yeah,
but
that's right. You might be, but if you thought, well, if it's the first baby and that labour's going to take 15 hours, then similarly, if the woman had two previous caesarean sections, then she's got no real choice but to have another section anyway. Yeah. So you see what I mean? There's that's the detail we don't have.
Yeah.
But I think it's a case that really makes the point that some of these therapeutic dilemmas they're meaty, they're interesting, they're fascinating.
Yeah.
And it's our job to help people make their way through the quagmire of the evidence and try and make a real world solution that actually works.
Yeah, because I think she said something about a vaginal birth being unknown, and wouldn't it be better with a known caesarean? I'm paraphrasing, but something like that. But we don't know that really either.
No.
Good luck, Nicole. I know that is a big pregnancy that you're having, and some big choices, and lots of communication with your team.
Yeah, I think regardless of the decision that's made, it sounds like she's in expert hands, and that will work out well whichever decision is made.
Right, let's move on.
Hi, Dr. Pat and Brigid. Thanks so much for your podcast. It helped me so much throughout my pregnancy. I listened to every episode. I now have an 11-week-old baby boy who was born by caesarean section. It was a category 2 caesarean after the little guy got a bit stuck after 9 hours of labour. I'm just wondering, what is your opinion on baby number 2? My obstetrician said that I didn't need to wait any specific amount of time, but I've read other places say, wait 18 months before having a second baby after a caesarean. I'd just like to hear your thoughts on this. Thanks. Bye.
Can I start by asking, I don't know what a category 2 caesarean is.
Oh, that's just the urgency.
Oh.
So in the hospital, if someone needs a Caesar, for ease of communication between the labour ward and the operating theatre, there's a category system. Category 1 means get around there right now.
Oh, that's what I call the lights and sirens.
Lights and sirens.
Yeah.
Category 2 is, we've got to do this pretty soon, but we've got time for you to get the hip replacement off the table and
which belongs to a person.
and it goes down in urgency from there. And then some are not urgent at all. So the question though was not about that. It was about timing for the next baby. This is one that comes up a lot. There's a surprising lack of evidence about peak timing, and a number of things need to be taken into consideration. Some places or doctors would say 18 months, and to the best of my knowledge, there's no particular evidence that supports 18 months over slightly shorter periods of time. Certainly, like any other tissue in the body, when we cut into the uterus, get baby out at caesarean section, the wall of the uterus has to heal, and we've got to give it some time to heal. The thing is, though, if you got pregnant again the next day, and very, very few people return to regular sexual intercourse straight away after a baby. But theoretically, if you got pregnant again very quickly, the uterus would still have at least the 9 months of the subsequent pregnancy for that lower segment to heal. And lots of people are breastfeeding or using some artificial contraception, and it's quite uncommon to be having another section within 12 months. And that, I think, is probably plenty. And there's certainly, to the best of my knowledge, is not compelling evidence otherwise to the contrary. So I usually say to people, this comes up a bit when people are having their first baby at 38 and they want 3. Highly legitimate and reasonably common situation these days. And so they're pretty keen to make a plan for a short period of breastfeeding, stop breastfeeding, reestablish ovulation, get pregnant again. So I don't mind saying what I say to my patients is let's just make sure there's a year from one section to the next.
Yeah.
If time is important, then I think that's reasonable to proceed with that sort of time frame.
Yeah. And we've had 13 months between our last two, and they're great mates. I love having them that close. It's hard though. Yeah.
Well, I think the question was about surgical safety.
Yes, that's right.
Not
emotional, not from a maternal depletion point of view.
Yeah. So there are definitely other factors. There's maternal depletion, and then there's ideal timing between babies and growing up together and so forth. But I think the question was specifically about obstetric safety.
Let's move on to this caller.
Hi, Dr. Pat and Brigid. My name's Stephanie, and I am 34 weeks pregnant with a breeched baby. My first child was breeched as well, although they did turn before 36 weeks. This time around, I'm mentally preparing that maybe baby won't, and I'll have to consider my options of either trialling an ECV or going down the elective C-section route. I'm keen to hear your thoughts on how to make the decision about ECV, how to weigh up the pros, the cons, the risks, the benefits, and just what your general advice would be, because right now I don't know how to make the decision. One part of me would love to have an attempt at a VBAC, and the other part of me just wants to do whatever is safest for baby. Any advice would be amazing. Thank you.
There we go. A baby moving from breech to cephalic at 36 weeks. How often does that happen?
It happens all the time, but I guess it's late-ish in the picture for that to happen. It's why we start having the conversation about how to have a breech baby around about 35, because you're probably stuck with a breech to a greater or lesser extent after that. More likely it won't turn around by itself late in the pregnancy, and sometimes you get a surprise. Occasionally on the day. Yeah.
Well, if she had her first that flipped and then she had a vaginal birth.
Well, she mentioned a VBAC, so I don't think she did have a vaginal birth. That's not clear from the situation, and it could be highly relevant.
Yes.
If the first baby was in cephalic presentation at birth but was born by caesarean section, then there's more to the story.
Mm-hmm.
And that would be taken into consideration, firstly, in the discussion about the pros and cons of ECV, external cephalic version, putting hands on the tummy and turning the baby around. Potentially more risky in someone who's got a scar on the uterus from last time. And then it's also sort of relevant again in that if she's had one section and we do a section this time for breech without an ECV or without a successful ECV, then we've had 2 sections, and most obstetricians would recommend any further babies also be born via caesarean section after that, based on the safety data of VBAC with 2 previous sections being pretty poor.
Right. I don't think we know the answer precisely to that.
No.
Maybe we could talk about the pros and cons of ECV.
I think that's probably a more instructive thing to do because there's a little bit of detail missing there, isn't it? And it could be highly relevant. With ECV, there are, like all medical procedures, risks and benefits. And one of the things that I find when I discuss ECV with people is we've really got to explore the immediate risks of doing it. So it is theoretically possible that when you try and turn the baby around like that, you could damage the placenta or tie the cord in a knot, so these sort of things that might require an immediate section. So we do ECVs in hospital, okay, so that if something goes wrong, we can just go up and do an immediate Caesar. So done in expert hands in a hospital, there is, give or take, a reasonable chance of success, manageable risks, right, in a hospital. And the question, of course, is whether that person considers all of that, including the risk, to be worth it to them. And a lot of the time, if somebody has had no previous sections, and therefore if they had this baby, the breech baby, by section, then that would only be one, and they could have the rest of their babies born as VBACs, vaginal birth after Caesar, then they might say, well, hang on a minute, why don't I just have a section for this baby? Because give or take might be the smartest, simplest, most straightforward, potentially safest way to have this breech baby. And if the other ones are head first, I'll have those as vaginal births. We've got to discuss pros and cons, VBAC, yes, no, ECV, yes, no. What are my alternatives? What do I think about that? And what are my motivations? What do I fear the most? Now, some people think the idea of putting hands on their tummy and turning a baby around is horrifying, and they don't care about having a section. The way forward for that person is pretty clear. And someone else might feel the exact opposite. Willing
to give it a go. Yeah, I don't know. And then, what's the chances that baby after an ECV could just flip back up breech?
Sometimes they do, yeah.
Yeah.
Breech has got probably a lot to do with fetal behaviour. Sometimes people imagine that their uterus is a certain shape and that's doing it. In my experience, the shape's not different. You might have a big lower segment fibroid that's stopping the head go down or something like that. But the baby being breech at full term is probably mostly to do with where the baby wants to be. Yeah,
prefers to be head up.
Yeah, for whatever reason, and certainly babies come out head first for a good reason. The human babies, they like to kick, and there's more room at the top of the uterus to kick. So they like to kick their legs around in the big space at the top, which is why the head comes out first. And if you look at other animals across nature that have a different shaped uterus, a lot of those babies come out preferentially feet first.
Yeah.
Exactly. Yeah. So it's a lot to do with fetal behaviour. And certainly, you can go for an ECV and be back breech again next day.
Do you do the ECVs very often?
Yeah, look, I don't anymore. I did train in it. I certainly offer it to people, but I don't do it myself anymore. There are some procedures that they're not for the weekend enthusiast. They're probably things that you should do a lot of or none. And I always thought ECV was a bit of a knack. And the best people to teach you ECV when I was doing my training were the old boys who because back in the day, Caesars were rarer and things had to be more pathological to get a Caesar in the first place. So they used to do a lot of more adventurous vaginal births and things like ECVs to keep vaginal birth on the table. And so the more senior guys had more experience with it. But I've got some colleagues who are good ECV people, and I send them to those people for an attempt at an ECV if they're keen.
It's like those around still that can perhaps deliver a vaginal breech birth.
Same deal.
Maybe getting to be a bit more of a lost art.
Yeah.
All right. Well, good luck. I hope your baby, magically just flips by his or herself and goes cephalic and you have a great rest of your pregnancy and birth. We're going to move on to someone that we know.
Hi, Pat and Brigid. My name is Olivia, and you both actually know me. Pat, you work with my mum, Anne, and I am related to your brother and family. So, yes, I am actually 30, coming up on 33 weeks pregnant now with my first child. And I guess my question, obviously love listening to the podcast, very much appreciated for all the content that you do put out. My question was, I plan on having my partner as well as my mum in the room as support partners, birthing partners. I guess I just wanted to ask if you had any tips in terms of, one, towards fathers who may not be super experienced in the whole area, as well as even, Pat, if you had any experience or colleagues of being birth support partners, as well as a medical support, as well as a medical professional, and how you managed to kind of be the emotional person as opposed to just wearing your medical hat, what that looked like, difficulties or tips. Yeah. Anyways, thank you very much. And thanks again for the podcast.
Oh, brilliant. That's great. That's excellent.
We knew Olivia, we haven't seen her for 10, 15 years, have we?
Yeah, I know who Olivia is, and
but she was like a child.
A child, yeah.
We are getting old.
Yeah, we are. Congratulations on your pregnancy. I think that this is a cracking question because it brings up what's that support person really for.
Yeah.
Yeah. So we'll divide it up. The partners are there wearing a number of hats. That they're there to witness the birth of their own child, but they are also there in an important support role for the labouring woman who is in need of support. She's in pain. It takes a long time. There's a physical and emotional stress. And so in my time in obstetrics, I've found that for partners, one thing that really works, probably the main thing that really works, is to have a clear portfolio and a clear job. So if you're going to have multiple people there, I've seen it cause problems when it's not clear who amongst the support people is in charge, if you like, and we certainly don't want conflicting opinions. So a portfolio system works very well. And I think that I'll make a big generalization. I think for male partners, dads, a clear role is gold. I think that really works well. And it works well for that person to be able to resort to fulfilling their role as the labour ramps up and the pain might ramp up and the general level of anxiety and distress in the room may ramp up. So for partners, a clear job. You're the massage person or the change position person or the count the contractions person or the bring the cold compresses person, and that role is respected and we don't have multiple people doing the same thing. Works quite nicely. And then if we're going to bring in another person, that's fine if we sort of have that portfolio system. But the medical person is a challenging one. I have certainly been the obstetrician for medical families, for doctors where the labouring woman is a doctor or where their partner is a doctor, and on multiple occasions where they're both doctors. And that's a challenge. On the one hand, you have the benefit of a medical person who sort of knows what's going on, who knows what's going on in the mind of the supervising obstetrician, and that can be useful in cutting to the chase. On the other hand, we don't necessarily benefit from a whole lot of extra opinions on things. So yeah, that's a challenging one.
And it's a challenging one because obviously we know your mum, Dr. Anne, and Anne is also a talented, experienced birth provider. So
that's right. Yeah, that's right. So overall, I think it sounds like you've got a terrific team. And I see a lot more strengths than weaknesses in this plan. Yeah, a lot more. But one of the things that I have found to be very valuable is clear planning in advance, and that the labouring woman has clearly expressed her preferences to those people.
Yeah.
The ones that I've seen go poorly is when the support people have turned up on the day with conflicting views about what their job is.
Yeah.
What they're there for.
Yeah, and perhaps even what the birthing person wants in
that's what I mean. Yeah,
labour.
absolutely.
Yeah.
And then the birthing person in between contractions has had to say, no, that's just not what I wanted.
Yeah.
Yeah.
I think a dinner out with both of them at the same time and taking your preferences and then just sort of talking around both with both of them what their role is and what they expect.
Clear as kind.
Clear as kind. Now, to help you too, Olivia, obviously we've got the free podcast with Mitch Pappas where he's talking about being a supportive partner in general. But in the program, the Grow My Baby program, which you may not have got to yet, is another exclusive podcast just for Grow My Baby members, which is him talking about how to be the best support person during labour. So maybe just get your partner to have a listen to that because, you know, what Mitch studied, researched, got up to speed with before his partner's labour is gold, and you know he just really describes it beautifully. So yeah, go back and have a look through the program. I can't remember what week it's in, but have a look through and see where you can get some more hints from that.
Perfect.
And good luck. And maybe a podcast suggestion. Just putting it out there, Olivia. Maybe you and your mum can come in after your birth.
Oh my God!
And we can talk about how the support.
If you didn't fall out in labour.
Well, I'm sure, you know, even if there were moments, you guys are tight, so you'll be fine afterwards. So, yeah, that would be...
How exciting for you guys. That's great.
It's very exciting. Congratulations. We've probably got time for one more.
Hello. I'd like to remain anonymous, please. Not currently pregnant, just a quick question, looking to get pregnant in the next 6 months or so. Wondering, I've heard that you should wait for a period before, after coming off the birth control pill before getting pregnant or before trying. And just wondering, does that mean a withdrawal bleed from coming off the pill? Does that count as a period, or should I be waiting a further month after that first withdrawal bleed after coming off the pill? Thank you. Love the podcast.
Yeah, that's a good question, isn't it?
Yeah, and this is someone being super organised.
Yeah, and someone who knows the difference between withdrawal bleed on the pill and a naturally occurring period. I think that the whole point about waiting is really only for people who want to have the first day of a normal period to reestablish when their new day one is in a new cycle. So you can count forward 2 weeks to when about the day 14 is when ovulation would be expected and concentrate intercourse around that time. I don't think there's any particular problem in itself with conceiving before then, other than that you might not know exactly when that first ovulation occurred and therefore what your dates are. But that can be rectified with a first trimester ultrasound, where we can measure the little embryo when it's really small and establish the dates from there.
Mm.
So, for example, someone comes off the pill, they don't have a period for 7 weeks. They think, where's my period gone? Do a pregnancy test. They're already pregnant. So what's happened is they've come off the pill, they've ovulated before they've menstruated, conceived, and never got around to that first period. And then the only drama from that is that dates are a little unclear.
Yeah.
So if you want to avoid that trap, then you just have the period at the end of the pill use, so the withdrawal bleed, one natural period. That tells you when the new day one is, and you can accurately date a pregnancy from there.
Yeah. I also want to say, only from years of doing this now, some people are surprised that their period sometimes doesn't come back immediately.
Yeah, that's right. It can take a little while to come back. And that's just a post-pill thing.
Mm.
And it's a problem because if you assume that's going to happen to you, you might conceive in the first cycle. And if you assume that it won't happen to you, then maybe it will.
Yeah.
So just have to stop the pill when you're ready. See how you go.
Yep. Good luck. We want to hear from you too once you do come off in 6 months, 7 months, you know, see how you're going. That'd be exciting.
I like someone who's planning it. That's fantastic.
Yeah, that's right. And getting themselves ready and getting their bodies ready and, you know, there's mental preparation to do as well.
Not to mention seeing the local doc, going on some folate or having a pre-pregnancy genetic screen and so forth.
Oh, which is also, I'm going to say, which is also in our Getting Pregnant program. So, I mean, it's cheap as chips, $67 to get our gold in there in how to get ready to be pregnant.
Perfect.
So everybody, that's us for today. Thank you so much for joining us. We do love these episodes. We've got some exciting guests coming up, and as you know, we've moved on to this new platform with Mamma Mia, which is also very exciting. Lots of new listeners. So thank you so much for all your efforts and encouragement and all your 5-star reviews. We absolutely love them. And if you want another freebie, we have a newsletter which you can sign up to. It gives you week-by-week information and links to all the podcasts that are attached to that week's information. So it's a good way of making it chronological.
Fantastic.
So just go onto our website, growmybaby.com.au. Bye for now, everyone.
Thanks for listening, everybody. Bye-bye.